Welcome everyone and happy Thursday. I'm excited to introduce you all to our webinar today that's titled Standard 5.8 Lung Nodes, which stands for Nodal Operative Dissection Evaluation and Staging. This is an informational webinar for the new ACS Cancer Program's National Quality Improvement Collaborative that will be starting in January 2024. Next slide, please. Now, before we get started, let's go over a few logistics to help this webinar run smoothly. We're excited that we have over 1,000 participants registered for this webinar, but unfortunately that means that we will have to, we will be unable to turn on our webcams in order to provide the best visual and audio for you all. Other technical logistics that we need to go over, all questions, including any technical issues that you may be experiencing, should be submitted through the question pane on the side. We will have some time for Q&A at the end of the webinar, and we'll answer questions as time permits. Additional questions and answers will be posted on the website. We also ask that you complete the post-webinar evaluation form that will be sent about an hour after the webinar ends. This not only gives us feedback about how we did today, but also provides us with suggestions for future content and how we can improve future webinars. Next slide, please. This is the panel introducing our moderator and panelists. I'm excited to be here. My name is Dr. Kelly Chan. I'm a general surgery resident who's the current clinical scholar of the ACS Cancer Programs, and I'll be moderating the session today. It is my pleasure to introduce our panelists who are experts in thoracic surgery and quality improvement for today's webinar. The first presenter is Dr. Matthew Factor, who is Assistant Chief of Thoracic Surgery at Geisinger. The second is Dr. David Odell. He is a section at the University of Michigan. And last but not least is Dr. Anthony Yang, who is the Professor of Surgical Oncology at Indiana University. Next slide, please. So on the agenda for today, I will be going through why a national QI project is important, and then the panelists will go through what exactly is standard 5.8 lung nodes, including the definition, the goal, requirements, timeline, accreditation details. We do have a slide as well on common FAQ, and then we'll have a Q&A session. Next slide. So why exactly are we doing a national quality improvement project? Well, the CoC has over 1,500 programs with a strong infrastructure in place, such that when we do a QI project, we have the potential to impact thousands of patients nationally. So far, we have seen success with 3 different national projects that I will describe briefly in the next slide. The biggest difference with this standard 5.8 lung nodes project is that we are focusing on improving compliance with an operative standard, and we will use a collaborative model. Next slide. This slide details the successes of our previous national quality improvement projects. We started first in 2021 with a return to screening, where we helped programs identify areas to improve outreach, utilize an intervention toolkit, and measure improvements in patients returning to cancer screening after the COVID-19 pandemic. Next, we had Just Ask, where programs worked on improving their rate of asking newly diagnosed cancer patients whether or not they smoked. The second year of this project was Beyond Ask, which improved on the first year by having systems improve support assistance for smoking cessation. And earlier this year, Breaking Barriers was implemented, which focuses on addressing barriers to cancer care, specifically related to missing 3 or more radiation therapy treatments. In the first year, 80% of programs have been able to identify patients missing appointments and root causes, and they are about to start their second year, which will focus on implementation of an intervention, engaging community partners, and sustainability. Next up. So we will now have Dr. Matthew Factor talk a little bit about what Standard 5.8 is.
Thank you very much, Dr. Chan, and hello and welcome everybody, and good afternoon to many of you on here, depending upon your time zone. Next slide, please. So we won't spend a ton of time here on Standard 5.8 as far as what it is exactly, but of course that's where it starts. What is this? What are we talking about? And probably most of you here are familiar with it. That's why you're on the webinar, to join this quality improvement program overall. But just as a reminder and sort of to level set, the standard itself is an operative standard from the standpoint of what happens at the time of lung cancer surgery. In the top half of this slide gives you the salient points. This applies to any curative intent operation for lung cancer. And when we say lung cancer, that's small cell, that's non-small cell, and that's carcinoid tumors. So if you're going in with curative intent, this standard applies, and it applies to and refers to the lymph node, the extent of the lymph node dissection, which we know is a problem around the country, if not the world, getting enough lymph nodes. Why does it matter? It has to do with improving the staging accuracy and therefore the treatment accuracy and therefore overall survival from lung cancer. If we don't have accurate staging, we're not treating properly, and that diminishes survival. And that has been shown in a variety of ways, but no, there is no randomized controlled trial telling us exactly how many lymph nodes to take out. So the goal is to get at least one hilar lymph node station and at least 3 different mediastinal nodal stations. I know this is technical and lung cancer specific surgery related and all of that, but that's what it is, the so-called 1+3 rule. At least one hilar node and at least 3 different stations worth of mediastinal lymph nodes. That's the minimum. Hopefully we get more than that, but you never know. And then this goes on to the pathology report. And the point here on the slide in the lower half is that our pathologists should be using the standard synoptic report format as required by the College of American Pathology. Next slide, please. And the reasons that potentially one may be non-compliant with standard 5.8, upper left corner of the slide, of course, if the surgery really is not done thoroughly, and these lymph node stations are not examined, lymph nodes are not harvested. So surgical technique, we know that's a big component here. Certainly all of these things have risk, but these are standard elements of a lung cancer operation. And an experienced lung cancer surgeon knows where all these nodes are, should be, knows the danger in those particular areas, things like that. But of course, first comes patient safety. And if it's not safe to enter an area, by all means, don't do that. Standardization within the operating room as far as communicating the specimen names to the staff in the operating room, and then that gets sent to pathology. If these are not documented well by the pathologist, that can be a reason for non-compliance. And overall communication, so surgeon, operating room staff, perhaps the circulating nurse, and pathology staff, all starting, of course, with the nodes coming out by the surgeon who is announcing the labeling of that node. Communication is key to get an accurate pathology report. We already mentioned upper right of the slide that worse lymph node harvesting or poor lymph node harvesting leads to worse patient clinical outcomes. Now, this is something that can be measured, of course, and if you can measure something, you probably can improve it. And that's the whole goal here, is getting real data behind what we have done with our lymph node harvests and improving that. Now, the specific goal for this so-called Lung Nodes National QI Collaborative is that 2 years from now, December 2025, that everybody participating, all the programs participating in this QI project, would get above what is expected, the 80% overall compliance rate, or improve by an absolute value of 20%. So the goal, of course, is to improve. And I didn't mention it earlier, but the compliance rate for standard 5.8 is now 80%. When it first started, it was 70% and went up 1 year later to 80%. It's a little bit arbitrary. It's not a perfectly selected number, but the point is, we know it's not going to happen 100% of the time. For example, yesterday I was doing a redo operation, and I had previously done a thorough lymphadenectomy, and this was a second cancer operation. So I fell short. I got 2 + 1, but I know exactly why I did. There simply was too much fibrosis in certain areas and just not any other lymph nodes there. Next slide, please. The next slide, when it comes up, we'll see it just kind of reiterates it, not in any particular order, but number one, we want to make sure that we are all using the synoptic format with pathology reports. That's very, very standard now. So hopefully not a problem for most folks. We want documentation to be accurate during the surgery. So again, that starts with the surgeon and what they're telling the operating room staff, what the labels are, using proper names and or numbers for these lymph node stations, not just random names of lymph nodes that are not standard. And then of course, encouraging communication among the whole team that's involved. And when the CoC comes around to do our site surveys, the surveyor simply is given the pathology report in order to see if we are compliant. And it was chosen that way on purpose because essentially the pathology report reflects everything that came before it. Not only that, but also the surveyor is checking to see if the synoptic format was used by the pathologist, so they can get a lot of information from a single document, which makes it easier for the surveyor as well. And then my final slide next, if you don't mind advancing. There are lots of resources. It does take just a little bit of surfing through the American College of Surgeons website, but going to cancer program, quality programs, and specifically cancer programs, and get to the toolkit for these operative standards, and you'll find yourself seeing the links that are on the left side of the screen. And then even cooler, there are a couple of videos on a slightly separate part of the website. I think it's where it's the operative standards for cancer surgery. There are two beautiful videos that you can see the pictures of them there, 12 minutes and 15 minutes long, demonstrating where these different lymph node stations are. Very high-tech type of video, well worth reviewing. So there's those resources. And there's even a QR code on this screen to help get you to these links quicker. Now we will move on to Dr. Odell and his portion.
Thank you very much, Dr. Factor. So Dr. Factor's just given us kind of the background on this standard and why it was felt to be important, and the work that he and his group in the standard section of the college went through to develop the standard. As we think about this National Quality Improvement Project, I'm sure what's on many of your minds are what will actually be needed and required of our programs if we were to choose to participate. So we're going to spend the next few minutes talking a little bit about what program participation will look like and what resources we hope to be able to provide to help all of you improve the care that your programs provide for your patients. So who should consider participating, and what are the things that might drive participation? And we really thought about this as what are the questions that you might be looking to find answers for? For many programs, we've heard that just purely developing a way to better understand their rates of compliance or non-compliance has been a challenge, and this program will help to provide some structure for that. It may be really, really valuable for programs to help get some help understanding the reasons or root causes why cases are non-compliant. For some programs, it will be to determine if there's a mechanism to review cases that are non-compliant and help to improve those rates of compliance, and what tools they might have for that. And finally, you may ask, are you aware of resources, and Dr. Factor just showed some that can help to overcome challenges with compliance to standard 5.8. But even though there are resources that are out there, how do we best adapt them to fit the way in which we deliver care within our own programs? Next slide, please. So go through a little bit of the nuts and bolts and nitty-gritty details. So first of all, we really want this program to be something that is as broadly open to all of our cancer programs as possible. So any accredited cancer program performing lung cancer resection is eligible. So at least one surgery annually is all that you need, because we really think that this is important and we want everyone to be able to be involved. Programs who have received a compliant rating are also encouraged to participate, because we really want to create a community of improvement as we think about this. And it's really going to be important to have folks who are doing this well, who can kind of help teach those programs who have issues that they want to address, some techniques and tactics that they might be able to use to address it. This, as with any program that's asking you to participate in things, it will require some work, and we want to make sure that you get credit for that. So there are two standards in which program participation can actually earn you credit. Standard 7.3 or the Quality Improvement Project standard, and of course directly addressing standard 5.8. So this is being conceived as a 2-year project. We are approved for credit for standard 5.8 in year 1 of the project. So if you have issues what you're trying to address, participation in this will help to fulfill that accreditation standard. And then these are projects that are approved year over year. So in year 2, we anticipate that if the project is going well at your institution, you would also potentially be able to receive credit at that point. As I mentioned, this is an arc of a 2-year project, beginning in the beginning of the calendar year, so January through December of both 2024 and 2025. And if we can go to the next slide, we can talk a little bit about kind of how we would approach this. So when we think about what types of patients and centers would be included, so much as for the standard, this is targeting adult patients, so not pediatric patients, but adult patients undergoing curative intent lung cancer resection by any means. So wedge resections, segmental or other sublobar resections, lobectomy, bilobectomy, or pneumonectomy. The standard is not meant to apply to patients who are undergoing lung surgery for diagnoses other than cancer, or for those patients undergoing lung resection without the intent of providing cure. So for example, biopsy for tissue confirmation, those cases would be excluded. It's also not intended to apply to those patients who are undergoing lung resection for treatment of metastatic cancers to the lung, so essentially for primary lung cancers. So what does non-compliance actually mean? It means either that the patient did not receive appropriate nodal staging, so as Dr. Factor talked with us about, at least 1 hilar station combined with 3 mediastinal stations being sampled, or that the required elements of staging were not appropriately documented on the pathology report in synoptic format. So it doesn't necessarily mean that this was purely a technical issue that led to non-compliance. So there are many aspects which we may target with this project. Next slide, please. So what will you be asked to provide? So in the first phase, we really want to understand what current program performance is like. So we'll be asking questions about your current lung resection cases and rates of compliance. How many cases were compliant? How many cases were non-compliant? And if available for those cases that were non-compliant with the standard, what were the reasons for that non-compliance? And again, this gets back to some of the issues that Dr. Factor talked about. Are there technical concerns? Are there issues with the team dynamics or standardization of sampling in the operating room? Are there issues with documentation or communication? Because the solutions that we need will vary based upon the phenotype of the problem. Next slide, please. So for those programs that are interested in getting started, this is a little bit of a roadmap for the things that you need to do. For those of you that have been involved in quality improvement projects, either in conjunction with the college or even locally in the past, I think you'll understand the importance of building a team that engages all the relevant stakeholders. So for those that are interested in thinking about this, start thinking about the construction of that team. We would recommend that there's a physician champion. It may be your cancer liaison physician. It may be others who are invested in this at your institution. You also need a clinician to serve as the project leader, and this is usually going to be someone who has some content expertise in the area. Because this touches in areas of both surgery and pathology, having members of each of those departments is important. We also think it's really important to engage our oncology data specialists, or those who are providing our data and analytics support, because they'll really understand some of these problems at a very immediate level. And then because most of this takes place within the operating room, involving members of our operating room staff, our nurses, our scrub technicians, in thinking about building these teams may also be of great value. Our application process is opening currently. The applications will be due at the end of the month of February. It's important here to get support from the physician champion at your institution. Differently from some of the previous quality improvement programs, such as Breaking Barriers, we will not need kind of long formal letters of support, but more kind of a sign-off of engagement. And then as the project begins, we'll start by kind of getting a baseline understanding of how all of our programs are performing, looking at rates of non-compliance, and then building a compendium of strategies for tracking in real time or near real time the trends in compliance or non-compliance. And then really looking kind of internally to understand your own workflows at your institution, and the resources or needs for information flow and technology. In year one, as I said, the application process will kind of open in those first couple of months of the year. We'll then move pretty directly into trying to help you better understand the compliance data for your institution. Our first phase working together will be to perform a root cause analysis exercise. So really trying to dig into some of the details that are drivers of non-compliance to help you understand the areas that you can best target for improvement. We'll begin tracking and submitting this data, and then we'll develop together cohorts of folks who are struggling or dealing with the same problems in terms of compliance with the standard. We'll develop interventions, and then we'll work together to implement those solutions in a guided fashion. The second year of the project, as it goes forward, will really be focused on continuing to support you in implementing the solutions that we've developed in the first year, continuing to track our performance, and really then shifting our focus in the second half of that second year of the project to how we maintain and sustain high levels of compliance as we move forward. Next slide. So I'd like now to introduce my friend and colleague, Dr. Tony Yang, who's going to talk a little bit more about some of the quality improvement resources that we have to help provide you support during the course of the project, and then address a little bit further some of the issues around program accreditation as they pertain to the project. Dr. Yang.
Okay, thank you very much, Dr. Nodal and Dr. Factor and Dr. Chan. So I'm the last one that's going here, and I'm going to answer some of the more, or give you some more general information that's pretty consistent with some of the other national quality improvement projects we've done so far, and just some of the nuts and bolts maybe related to some of the questions you might have. So let's go to the next slide, please. The question we get a lot is how much time is required for a project like this, and what you can see here that we approximate at minimum probably 25 hours of time annually. So then in year one will be spent on submitting data, so the one pre and one post survey, as well as 3 rounds of data submission, so quarterly data submission, and then attending and viewing up to 5 webinars and or group calls with programs in your cohort. Related to the, again, as we mentioned, we would have you cohort probably around the problems that you will be addressing, and doing that together with other programs and sharing experiences. This time does not include any team huddles, team meetings, or time spent on improvement cycles related to understanding your root cause analysis, or which we will help you figure out how to do in a meaningful way, or implementing or selecting and implementing your interventions. So let's go back one slide, sorry, before we move on. The last thing I want to mention here is we do expect that you will have your program will be meaningfully committed to meaningful participation in this project, so whatever time that takes, and that can be reflected in your effort will be the amount of time that's required. The next slide, please. Thanks. Another common question we get with these projects is how are we submitting data? So if you participated in a national quality improvement project before with your hospital, you'll know that the platform that we use for data collection is REDCap, and REDCap is a web-based interface secured to the American College of Surgeons. You do not need to purchase any software to enter data into REDCap. You'll be sent a link, and we'll be able to directly access the REDCap software and questionnaire regarding the data collection itself, yourself. This will be sent separately at each data collection interval. So again, no cost, no extra software is needed. Next slide, please. A couple notes on the data collection itself. We will not be asking you to collect identifiable patient data. I think that's very important in terms of protecting your patients' privacy. But we will be asking for data in ways that will be meaningful to you to be able to understand your problems related to standard 5.8 and how to act upon those. The pre-post surveys will collect data on current practices, perceived challenges and facilitators, and have some questions regarding your organization's readiness to change, and are not provider staff specific. So we're not going to ask for names of Dr. X who refuses to do mediastinal and pulmonary lymph node dissections or anything like that, but rather this helps the project team understand what are some of the common issues and how we're going to help you guys address those, and also help you understand maybe some of the areas you need to address as well. The ACS Cancer Programs has submitted an IRB application on behalf of the project for exempt and non-human subjects research status, which is common to QI projects. We have done this multiple times in the past for our other national QI projects and do not anticipate any issues with this. We always encourage you, if you have questions about this, to speak to your own institutional IRB, but it should be exempt as a quality improvement project, and again, that no identifiable patient data will be collected. Next slide, please. Just to reiterate the resources that are available to you, you've seen examples of many of these throughout the webinar today, which are additional webinars related around topics specific to this project. You'll receive technical assistance from the project team. You'll receive you'll be able to have access to a change package with helpful implementation tools, and you'll be able to participate in calls with other programs in your cohort as you go through this quality improvement project. So all of these, I think, are many of these are available to you today on either the cancer programs or CoC websites, or if you do some searching yourself. I think the value to this program is that we will help guide you through a quality improvement project related to standard 5.8 from beginning to end. And you'll be able to do that together with other hospitals who are facing similar problems such as you. You'll be able to share experiences, network with them, and also hear from hospitals that are doing very well with this and understand how they have been able to do that successfully. So a lot of guidance in relation to this, and helping you understand how to use the resources, the multitude of resources that are out there and sometimes overwhelming. Next slide. We did want to spend a little time on some other commonly asked questions that we've already been asked. Number one is, may participation be used to satisfy a corrective action? And this specifically is applied, I think many of you know this already, but if you are not compliant with standard 5.8 in a recent site review, or if that comes up in the coming year, yet can this be the corrective action related to non-compliance with standard 5.8? And the answer to that is yes. Participation and completion of requirements may be counted toward a corrective action, so participation in this project. Number two is, we do not have a problem with standard 5.8 compliance. We're doing pretty well. Should we still participate? And I think Dr. Nodal has mentioned this already, and that yes, we want to encourage you to participate, to serve as mentors and provide valuable best practice, not so much data, but information to us so that we can understand how we can help our programs. You guys have already done this in the real world, and though our project team has a lot of experience with this as well, I think learning from each other is the best way to do this. And so we would encourage you to participate, and you will still receive credit for standard for 7.3 in addition to your 5.8. One common question we received for network programs, so the INCP and the NCIN programs, Is this project done at the network parent level, or must it be done at each of the children? And I love this terminology. So this project cannot be done at the parent level. This must be done at the child level, so within your individual programs within your network. Number 4 is, what if we decide to participate then drop out before completion of year 1? Just to remind you, to get credit for 2024, you must demonstrate full and meaningful participation in the project. You are welcome to leave at any time without penalty, but you will be responsible for meeting the standards independent of participation in the project regarding standard 5.8, and you'll have to identify another project for 7.3. So it's not that you'll be penalized for it, but if you drop out before without meaningful participation, and we can help you deal with this on an individual basis if this happens to you, you may be responsible for identifying a different 7.3 project in particular. Last FAQ question is, can programs meaningfully participate in only 1 year? And the answer to that question is yes. So this is although this is intended as a 2-year project over time, we think of it as a 1+1 project. So for those of you that have participated in Breaking Barriers, this is very similar. So programs who meaningfully participate in year 1 can choose to and receive credit for it, may choose to join in year 2 or decide not to participate at that time in year 2. Though we would highly encourage participation both years, given the timing of the different issues regarding implementation of 5.8 and meeting that standard that will be addressed throughout the 2-year project cycle. Particularly at the end of year 2, we will be addressing sustainability, which means, which is specifically thinking about how you're going to maintain the improvements that you've made over the 1.5 years that you've participated in the project. And how are you going to understand how to re-examine your if you fall below compliance thresholds, and what plan do you have in place for being able to readdress root causes of that problem and how to improve. The other additional factor in this and making this a 1+1 year project is that new programs will be able to join in year 2. There will be some requirements around how you would enter into this National Quality Improvement Project in year 2, but that is a possibility. And so so you can participate in only 1 year. Next slide, please. We have a few important dates for you before we enter into our Q&A. The application will be due February 29th, so you have a little bit of time, whether it's to go to your cancer committee, discuss it amongst your institution, to think about the answers to the application, things like that, and ask questions to us. By March 10th, you will receive confirmation of your participation in the project, and then April 30th will be the big start date in terms of when pre-survey, signature support, and baseline data collection will be due. And so so you can please keep those dates in mind. We will be these dates will be available to you on the website as well. Next slide, please. One other reminder we want to give you all was if you are not attending already or not registered to attend, or I think maybe registration is not open already, but we want you to save the dates from February 21st, and I'll tell you why 21st in just a second, to 24th in Austin, Texas for the ACS Cancer Conference 2024. There will be a lot of content around quality improvement this year and thinking about how do we use quality improvement methodology and thinking to improve your performance on the CoC standards. There will be presentations from hospitals. There'll be a poster session with hospitals sharing their experiences. We'll get a chance to learn from each other and hear from the experts. Next slide. And you'll be able to get some good barbecue in Austin, by the way, too. And along those lines, why I set February 21st as to save that date as well for that half day when you're coming in anyway, is to consider registering for the quality improvement workshop called Meeting the QI Standard Beyond the Basics. You can see some of the topics here will be related to unpacking QI in cancer programs, reviewing data, writing your problem statement, which is a key to any quality improvement project, choosing and implementing PI process improvement methodology and metrics into your own cancer QI project, and presenting on QI. Who, what, where, when, and how do you present on QI? And I see a note in the chat that registration is open now, so and a link to the webpage will be included in your post-evaluation that will be sent an hour after this webinar is over. So we encourage you to attend. We'd love to see you all there. Next slide, please. I think at this point, I'm going to turn it over to our moderator, Dr. Chan, and Eileen Riley to moderate the Q&A session. Thank you very much, everybody.
Thank you so much to our panelists, Dr. Factor, Odell, and Dr. Yang, for their efforts in this project and for sharing their expertise. We are really excited. We have almost 700 attendees, and we're really looking forward to the collaborative aspect of this project, along with the mentorship that we can provide you in improving your QI skills and improving your compliance with Standard 5.8. We now want to open up to the Q&A. I do want to introduce Eileen Riley, who is the Quality Improvement Manager for the Cancer Programs. I know she has been answering some of your questions through the chat, but she will also be providing questions to us on the panel, and we hope that we can answer any questions that you have and provide you with more information about why it would be beneficial for your program to join this collaborative.
Great, thank you. Hi, everyone. Before we've had lots of thoughtful questions come in, so thank you so much for those, and we're going to get to as many as we possibly can today. Before we do that, I know just some admin stuff. People have been asking about the slides for this. I encourage you to go to the right-hand side of your screen and look at where it says handouts. You should be able to see the slides there and be able to download a PDF of these slides. The other thing I want to mention is that we do have a web page for this project. So things like this recording and the FAQs, we'll answer them today, and then anything we don't get to, we'll include on an FAQ document and post that all to the website. When the link becomes live to kind of complete what we're calling an application, it's not necessarily an application of you're accepted or denied, but just kind of our baseline. We want to get in touch with you and you want to express interest in participating. The link on that page, the link for that will also be kind of live on this web page. So I encourage you to QR code it, save it, favorites it, revisit it, and that's where lots of this information will be added to in the coming days, weeks, and months. So like I said, lots of questions, and I'm excited to dive in and hear from our moderator and panelists. One, though, that kind of keeps coming up, and I think Dr. Yang, I'd love for you to talk about this along with the others, is just that idea of the small n. So we've had quite a few questions about, we only maybe see 2 cases or 3 cases or even 1 case a year. Should we still participate, and what does that look like? So are you able to just kind of talk about the small n of it all?
Yeah, that's a tough one. I think it's especially, I think one of the way the questions came through was if our one lung resection doesn't come in until December of the year, of that calendar year, what do we do in that case? I think there's my initial reaction, and Dr. Factor and Dr. Odell, please feel free to weigh in, is to encourage you to participate, because this is not about the case as much as the systems that you put in place to understand how to be compliant with 5.8. And if the other things that will be addressed are understanding what your problem might be. So if your problem is that the surgeon doesn't want to do it, say, and he doesn't want a year, or he or she doesn't want a year, then how do you affect that change management to get your surgeon to be able to do the right thing? And so we would encourage you to participate. The other option would be to, if you're not sure if your volume is going to make it to 1 for that year, is to consider the 1+1 aspect of this, and maybe consider participating in year 2 as well. But we would encourage you to participate. I don't think we want to keep anybody from participating who wants to and thinks they will be a benefit from this.
Great, thank you. Our next few questions are more clinically focused, and so Dr. Chan, I certainly invite you to respond, or others, but one came in asking, as a pathologist, what is considered curative intent, so as to know what cases are excluded from the standard?
Yeah, this is Matt Factor here, and so that would come from the surgeon. I mean, it's a good question from the pathologist perspective, even the cancer registrar perspective, obviously, because they don't know what's going on clinically up front. But we're talking about this is surgically amenable disease, so certainly stage 1, and often stages 2, and now even 3 surgery is part of the upfront curative intent plan, but again, should be documented by the surgeon in their operative note. And it's, generally the primary therapy for the cancer, although that certainly chemotherapy and neoadjuvant immunotherapy and chemotherapy may be involved in that as well. So communication starting from the surgeon, and if need be, the pathologist asking the surgeon, hey, was this a curative intent operation? But just like how a synoptic pathology report is required for primary resections, that would tell you right there that it must have been a curative intent operation.
And Eileen, this is David Nodal. I would also chime in to say that the mere fact that for some of our programs, identifying curative intent may be a challenge is, in my mind, an issue that we may address through participation in the program. That is what the standard aims to identify. But if we have a number of programs that have a challenge figuring out which of the operations that are done for lung cancer are curative in their intent and which are intended as biopsy procedures, that's also an opportunity for us to improve the clarity of our documentation and communication within the teams. And from my perspective, that may very well end up being one kind of problem that we develop cohorts around as we think about the QI project itself. So I think you hit on an excellent point in the chat with that question, and I actually would say it's a reason to participate.
Great. There's a few questions. I believe it's kind of the same, through the same vein here is what about the wedge resection? So some physicians, might not be particularly bought in. Others are, thoracic surgeons are saying, we're classifying these wedge resections as not curative. And so they're being excluded from the standard. Are there situations where they should be included?
So I can take this one as well. We actually now have randomized trial data that supports the use of wedge resection as a curative intent operation if it's done with appropriate nodal staging. So I think within the thoracic surgery community, this would be considered a curative intent operation and would be absolutely appropriate to include within the standard. And if this is the approach that surgeons at your institution are taking for some or all of the cases that they do, I think it's still important to ensure that we're doing those operations at a high quality, and that would include making sure that appropriate lymph node staging is a part of the operative care of that patient.
Thank you. So CAP does not require a synoptic report for lung resection patients who receive neoadjuvant chemotherapy and have complete response. Is the college asking for more than what is required by CAP for these patients?
Dr. Factor, do you maybe want to speak to that? Yeah. Yep, exactly. No, we're not going beyond CAP. No, absolutely not. But the following neoadjuvant therapy, it is still standard of care for harvesting, doing a thorough lymph node dissection to understand what exactly is left of the disease. And of course, it's always wonderful when there's a complete pathologic response.
Great, thank you. We have a few more accreditation focused questions. One's regarding the INCP of it all. So, I know we had talked about, do you participate at the parent level or the child level? To kind of be very direct, we use the words parent and child in accreditation here, but parent is actually kind of fictional, and it's just a parent is considered everybody over the network. So all of your programs are considered children. There's no one main program. And I know that might be kind of confusing, but so when we say you're participating at the parent level versus the child level, what we mean by that is if all of the facilities in your network, suppose you have 2 or 3 facilities, all of them do perform lung resections, you can participate as a network, and that would count as one of 2 QI projects you're supposed to do as an INCP. If suppose 2 of the 3 do perform lung resections, but 1 does not, you wouldn't necessarily be participating as a network. You're participating at the kind of individual site level, and that's a site-specific QI project, and this is what it would count for. So I hope that's clear, but we do have a document we're working on that kind of outlines the specifics for INCPs, because we know this is, you know, a little confusing for folks sometimes, the way we talk about networks. And so we'll add that to our website when it is available. One other question that's coming in is where are we getting this baseline data from? So when we're talking about submitting baseline data, is it 2023, 2022, which is typically what's abstracted? So Dr. Chan or Dr. Ying, are you able to speak to kind of what we are meaning by baseline data? Where is that coming from? What year?
Ellie, do you want to handle that one, or do you want me to?
So we will be expecting data from 2022, and that will also be helping you to really take a deep dive into how to collect this data too, whether it's through the operative reports or the synoptic pathology reports.
Great, thank you. I am continuing to scan because, like I said, we have so many questions. Let's see here. Are cases where cancer is not known at the time of cancer included in this standard? And I think that may have been incorrectly worded, but cases where there's cancer that's not known at the time of the operation included in this standard, does that, might that make sense for our subject matter experts here?
Yes. Yep. No. Absolutely. So the you know, most likely not, and it may be misinterpreting the question, of course. So happy to be corrected, but absolutely, there are times when we go to the operating room and the diagnosis has not been firmly established. However, that is your one opportunity to complete the operation and the staging all at one setting. Lung cancer is a significant endeavor when we take it to the operating room. We don't go to the operating room twice for lung cancer, not that you do for many other operations either, but you know, a melanoma might get a small shave and then go get a full resection, but not the lung. And so you need to be prepared that the final pathology 1 week later is coming back with potentially with cancer. So you should be doing the lymph node dissection at that same time. Again, if it's a scenario that I'm thinking of where you've got a suspicious lung nodule or maybe even a lung mass, and for whatever reasons could not be or did not need to be biopsied ahead of time, your intention should be curative intent for that, because again, we don't come back and finish the operation a week later. That's way too much risk for the patient.
Great, thank you. Another question, the thoracic surgeon at my facility expresses concerns that the requirements of standard 5.8 are different than those of the NCCN guidelines as far as what lymph nodes to remove and how many. Has this come up previously when discussing, and what would be the best information to relay to my surgeon?
They're not. The NCCN says to get at least 3 different mediastinal lymph node stations. It's exactly the same. Okay. And higher lymph nodes just come along with it.
Great. Let's see. Is this non-small cell lung cancer only?
Nope. Any curative intent lung cancer operation, small cell, non-small cell, and carcinoid.
Great. When Dr. Odell mentioned cohort, will this be led by a thoracic surgeon? I'm going to say yes, Dr. Odell.
So when we talk about cohorts, what we really are thinking about is grouping hospitals together who are facing similar problems. Some of these may be led by a thoracic surgeon. Some of these may be led by a pathologist or someone who comes from the operating room environment. It really depends on what the problems are. But you will be provided with folks who can be kind of content matter experts. So for example, if we're dealing with an issue of surgeon compliance or technical skill, yes, those would be things that we would have surgeon leaders who can be in a position to help you with that. But if this is, if the issues being faced are with helping to determine how a specimen is dissected and processed in the pathology lab, I consider myself to be fairly well versed in quality, but I think there would be probably aspects to that my pathology colleagues could speak to much better. So we have a multidisciplinary group on the project team side, and our hope would be to maximize the skill sets of everybody involved to kind of have the most on-target guidance possible for each of the problems that we find our participants are facing.
Great, thank you. Let's see, kind of some of the same that I've been, keep coming up in this question box is that we're doing pretty well with this standard, or in other projects, even if we're doing well, we were still encouraged to participate. Is that true for this one? So Dr. Chan or Dr. Yang, don't know if you want to comment on, again, just if you're doing well with the standard, is this an appropriate project for you?
Yes, we would encourage programs that are doing well with this standard to join us, just so that they really can provide their best practices and share their experiences with programs who may be having difficulty or may be facing the same problems that they previously had in the past. I think it's a good chance to really network with other programs and just provide the best practices that they can share.
And if we get through the first year and are compliant, can we still join for the second year of completeness and get credit for that second year?
Yes, we would definitely encourage programs to participate in both years, especially too if they're able to obtain compliance. Then the second year they can focus on achieving sustainability of that compliance, and then also sharing with other programs their success stories as well.
Now, I do want to clarify that for the second year, we'll, as we've done with the other national quality improvement projects, we will need to go to the accreditation committee and receive approval at the end of the first year for the second year for the project to continue. I don't anticipate any problems with that. The only reason why it might not happen is that if everybody improved by the end of year one and we don't need to go to year two, and everybody was compliant with the standard, then they might tell us we probably wouldn't give you credit for year two because you guys are all doing well. So that's about the only scenario that I can foresee, in my opinion, that we wouldn't, that we'd have an issue. So I cannot guarantee that you will receive credit for year two, but the anticipation is that if you meaningfully participate in both years, then you will receive credit for 5.8 and 7.3 pending approval in the second year.
We received a non-compliant for standard 5.8 with our recent review. We haven't performed these procedures since 2021, so we don't have data for 2022. We look to onboard a surgeon in April of 24 to continue these surgeries. Are we a good participant for this program?
I'll take that one. I think baseline data is going to be important for you all to understand what your problems are. And if you have a new surgeon coming on in April of this coming year, that would probably make year one very difficult for you all in terms of you can't really rely on past history anyway with a new surgeon coming on board. You may be an ideal participant to think about starting in year two with an eye towards collecting some of that data even during the year that those 8 months that your surgeon's coming on board. If you have interest around that, we encourage you to reach out to us individually for these kind of individual situations, and we can talk through that with you all as well and try to understand with the subtleties of that if that's the right decision for you. But my initial reaction to that would be probably best to join us in year 2. If there is baseline data available for you all that you can utilize, that would be useful to your surgeon that's coming in, and to change your systems there, then we can consider year 1.
Great. And looking at time, I know we're almost out of it. We have so many more questions, but I think we have time for one final one. And again, I want to mention that even if we didn't get to your question and answer it, we're going to take all of these back, develop a FAQ document, and post that to the website. So give us about a week or so to get that up on the website. We're going to answer all your questions. But this last one here, I'm a pathologist. For all resected primary lung cancer specimens, we use synoptic report to document the lymph nodes, even if we do not know if the procedure is curative. Would this be a problem?
I could take that one, Eileen. No, that's not a problem. What would really influence the compliance rate is the understanding of intent. I think it's best practice to use that synoptic report formatting kind of regardless. But it really will come down to, in terms of the inclusion in this project and really the standard assessment, whether or not this was curative intent or a non-curative intent procedure. And again, helping us to kind of better understand how to categorize those patients may be one of the things that this project can really address. But I think the way that you're doing it is not problematic.
Like I mentioned, there's a lot of questions, and specifically about eligibility and if this is the right project for us, or what to include or not include, some data questions, and we'll get back to all of those. But looking at the time, I want to throw it back to Dr. Chan to wrap us up.
All right. Thank you all so much for joining our webinar. We're really excited about the attendance that we had today, and I just wanted to say thank you again to the panelists for sharing their expertise. And we did show this next slide. We just wanted to give a plug for Clinical Congress of next year, that we are changing the dates slightly. It's a new Saturday to Tuesday program, so hopefully more people will be able to join us at Clinical Congress. But like Eileen said, we will send out the Q&A answers to all your questions shortly within the week or so, and then there will be a post-evaluation form that we'll send out 1 hour after the webinar ends, as well as a recording. So thank you all again for attending, and we're looking forward to seeing who will join us in 2024 for National QI Collaborative.